We'll go ahead and get started. We are going to talk now about the common congenital heart diseases. There's a bunch of congenital heart diseases. Some of them are much more common than the other ones, and those are the ones that I think you should concentrate on. And there's other ones that we're going to briefly mention and just kind of tell you a little bit about what they are, but I don't think it's anything that you need to be really responsible for. The more odd ones are the ones that, the cardiologists are going to worry about, and you're going to probably refer from your clinic regardless. Most even these common ones, you're going to refer probably to a cardiologist if the owner is interested in trying to fix the animal. So the common ones that we need to kind of worry about today are listed here. It's a patent ductus arteriosus. Everybody loves acronyms, so everything has an acronym. So it's a PDA. The ventricular septal defects, which is a VSD, the atrial septal defects, the tetralogies of Fallot, and that's pronounced Fallot. It's I guess a French guy. And so they're all kind of strange anyway. And so it's Fallot instead of fallout. I would just say fallout if it's not, but it's Fallot. And then you have the pulmonic stenosis and the aortic stenosis. So let's talk a little bit about each one of these and what they are. The uncommon ones that you don't need to be responsible for are listed here, and we'll again briefly go through those here at the end of this lecture. So a patent ductus arteriosus, what the heck is that? Well, if you remember from anatomy and especially from embryology, which I'm sure was one of your favorite classes, the ductus arteriosus is a specific connection. It's like a little blood vessel that connects the descending portion of the aortic arch to the main pulmonary artery in the heart or next to the heart. Okay. The function of a ductus arteriosus is to be able to return blood back to the heart from systemic circulation for an embryo, so something in utero. Immediately once we are born or an animal is born, the ductus arteriosus should immediately close off, and that will then allow blood to go out of the right side of the heart to the lungs, and then from the lungs back to the left side of the heart. Okay, so it's a bypass. The ductus arteriosus is a bypass of the lungs that only happens in animals that are in utero. Well, every now and then things screw up. And the congenital defect where the ductus arteriosus does not close automatically, then that ductus arteriosus is still patent, and that's where you get the name. It's a patent ductus arteriosus. And again, specifically, you need to know it connects, and notice the underlying word there, the descending aorta to the main pulmonary artery segment. If a person or animal has a patent ductus arteriosus, typically the flow of blood will be going from the left side of the heart to the right side of the heart through that ductus. Okay? And the reason, what dictates the direction of flow in all of these congenital heart defects is the pressures. So if one pressure on one side of the heart is higher than where the ductus is going, it's water. It's going to flow downhill. And so it's going to go from an area of high pressure to low pressure through a path of least resistance. And in this particular case, is the pressure inside the descending aorta higher normally than the main pulmonary artery segment? Yes. And so it's going to go from the descending aorta, blood flow will flow from that area and into the main pulmonary artery segment. So it's going in a left to right direction. Okay. Now here's the key and the weird thing about a PDA. Even though blood flow typically in a PDA is left to right, the blood flow ends up not in the heart, but in the main pulmonary artery segment. So again, blood flow goes from the aorta to the main pulmonary artery segment. It never goes into the heart. Okay. And so once the blood then goes into the main pulmonary artery segment, where does it go after that? Well, it goes immediately into the lungs and then returns from the lungs and gets dumped back into the left side of the heart. So because of that anatomy, we have a shunt of blood from the left side to the right side, but it never goes into the heart. It immediately goes back to the left side of the heart. So we have a left to right shunt of blood that results in a volume overload of the left heart. Okay, you'll just have to think about this and review the anatomy. I will show you a picture in a minute that will help you. But again, think of it, even though it's left to right, Yes, but in this particular case, the blood never goes into the heart. It goes into the main pulmonary artery segment, which immediately goes off into the lungs. And then once it's in the lungs, it immediately goes back to the left side of the heart. So it's a volume overload of the left heart. Typically, these dogs will have some typical clinical signs. If you feel their pulses, they'll be really, really boundy, very exaggerated water hammer-like pulses. And radiographically, you'll see enlargement of portions of the left side of the heart because of this volume overload, which I'll show you. And a lot of these dogs will have a very typical murmur that people will describe as a washing machine type continuous murmur if you listen to them. Any dog can get a PDA. They're more common in small breed dogs. And the good news is in almost all of these dogs with the PDA, you can fix them. So there's different ways to fix them. You can surgically ligate the PDA, but also non-invasively now they're putting little ligation coils that's non-invasive. You pass a catheter and find where the PDA is, and you can put these little occlusion devices inside the PDA that will cause a big blood clot to form and essentially clog it up. Okay, so let's look at an example of this. Radiographically, you see enlargement of the main pulmonary artery segment. Well, why would you see that? Well, you see that because you have this abnormal blood flow going from the aorta to the main pulmonary artery segment. So we got a bunch more blood going to the MPA, and so it becomes enlarged, okay? Then we also see a bulge of the descending aorta. Well, why would you see that? And you'd see that because, again, the PDA involves the descending aorta, okay? And then you also see enlargement or a bulge in the region of the left atrium and the left auricle and the left ventricle. So all of the chambers on the left side of the heart become enlarged. And why would you see that? Well, because the volume overload is the left side of the heart. So all of those chambers become big. Okay, so here's a diagram of a heart, and this demonstrates what a PDA is. So just to get you familiar, you're going to see some of these coming up here in a row. So this is the anatomy of the heart. This will be a good review for you. So let's look at the anatomy of the heart real fast before we just talk about the PDA. So here's the left ventricle, okay, and here's the right ventricle. Between them is a muscular wall called the interventricular septum. And then this is the left ventricular free wall, and this is the right ventricular free wall, okay? Notice the left ventricular free wall is always going to be thicker than the right side in a normal animal. And that's because the left ventricle is the main pumping part of your heart, okay? So it gets worked a lot. And because it gets worked a lot, just like your muscle in your arm, if you worked it a lot, it becomes thicker. Okay, so the pressures in here are much higher than the pressures in here. So now let's look at the rest of the heart. So up in here is the right atrium. So it's a thin-walled chamber, and it accepts blood from the cranial vena cava and the caudal vena cava coming from the head end and the tail end of the dog. So it comes in here, dumps into the right atrium. Okay, then it sits in the right atrium for no time at all and gets swept away into the right ventricle. Okay, and it goes through these valve leaflets right in here, and those valve leaflets are called the tricuspid valves. Okay, once it goes into the right ventricle, pretty soon this right ventricular wall will contract and it pumps the blood through the pulmonic valves into the main pulmonary trunk, okay, the pulmonary artery. The pulmonary arteries will then branch, and here's the left pulmonary artery, and this is the right pulmonary artery coming through here, right? And then the blood goes out in the lungs where it gets oxygenated, and then it picks up its oxygen load and comes back to the heart. And it comes back to the heart and comes into the left atrium through the pulmonary veins, okay? So here's the left atrium receiving blood coming back from the lung, okay? So now we have a big left atrium right in here, and immediately the blood from the left atrium gets swept into the left ventricle. It goes through these valve leaflets, which are called the mitral valves, okay? It sits in the left ventricle until the heart contracts. And once it contracts, it pushes the blood out through the aortic valve leaflets into the ascending aorta. Then you have the aortic arch, and then you have the descending aorta, okay? And from the aortic arch, you have all these brachiocephalic trunks, and that go up in here and supply the head and the neck and the front limbs with oxygenated blood. The descending aorta spins around this way and goes all the way down into the abdomen and branches off and supplies the caudal end of the animal. Okay, so the PDA is this little connection here. Remember, that connects the descending aorta right here. That's the PDA to the main pulmonary artery segment. And again, in a normal animal, right after birth, magically, this blood vessel that is normal in utero should close off. Okay. And then once it closes off, that allows normal systemic circulation and pulmonary circulation like we think about it in a normal animal. Okay. But if it doesn't close off, the result is now we have blood. Every time the left ventricle contracts, it's going to push blood out the aorta. Some of the blood is going to come down the descending aorta, but some of it is still allowed to go through this PDA. And when it does that, it will cause go into the main pulmonary artery segment, goes into the lungs, the blood comes back to the lungs, and volume overloads the left heart. Okay, so the PDA is right in here, and to fix that, they go in surgically and they find it and tie it off. They tie a ligature around it, or they can go in with a catheter non-invasively or less invasively and put an occlusion device in the PDA that will stop it up. Okay. So this is a VD view of a dog that has a PDA. And some of the times you really won't see anything at all abnormal on the radiograph. Sometimes you'll see hints that they might have an abnormality. The common things in all of these congenital heart defects, they're going to be young dogs. Okay, they're going to be a few months of age, so maybe 3 to 6 months, maybe 8 months of age. Every now and then, but rarely, you'll discover a congenital heart defect in a dog that's 5 years of age, right? But it's pretty rare to have that, but every now and then it does. Okay, so on this VD view, we can see, we said we should have a bulge of the descending aorta. Well, this line here is part of the aorta coming up. And this, it's a little bit prominent right in here, which is the descending portion of the aorta. Okay. And then we said we also get a bulge of the main pulmonary artery segment in a dog with a PDA. So right in here, we get a little prominence of the main pulmonary artery segment at the 1 o'clock position. And then we also said it causes enlargement of the left atrium, which is this in the bow-legged cowboy thing right in here. Mild prominence of the left ventricle, and look at this little prominence right over here between 2 and 3 o'clock. And what lives there right between 2 and 3 o'clock is the left auricle, which is part of the left heart, so it also becomes slightly enlarged. Okay, on the lateral view, if you look at a dog with a PDA on the lateral view, really you don't get a whole lot of hints of what's going on. Everything looks pretty normal. And sometimes on the VD view, this is pretty mild, this is pretty subtle. But sometimes it's pretty damn obvious. It's really obvious. The nice thing about a PDA, when you're talking about a PDA, is most of the time, this is probably the most common congenital heart defect in animals. And you can typically diagnose it with a stethoscope, okay? Because it has that distinct continuous washing machine murmur that it's kind of like a kind of murmur, right? And you can hear that with your stethoscope, and not many of the other congenital heart defects have that kind of a murmur. And so for the most part, you can diagnose it with a stethoscope. However, they're always going to do radiographs on it to see how severe it is, and probably an echocardiogram to help confirm it. And then you can decide if you want to treat it. So in this particular case, they didn't ligate it. They passed a catheter in here, and here's the descending aorta. Here's the left atrium. And here's the connection. That's the PDA right in here. That's the abnormal PDA. And this is in an animal that has the PDA, and now they've come in and they put this coil occluder device now. And so now whenever the heart contracts, all the blood goes down the descending aorta and none of it can go back through the PDA anymore. So that's how they fix that, okay? And this is where the cardiologists come into play and they do things, magical things like this. Okay, so the next one we're going to talk about is a ventricular septal defect, or VSD. So a VSD is relatively common in cats, in kittens, I should say, I guess, and in golden retrievers and Irish setters. So let's go look at some pictures. Okay, the VSD happens, it's just what it says. It's a defect in the interventricular septum. So it's a hole in the interventricular septum, which is the muscle between the left ventricle and the right ventricle, right? Okay. Most of them occur up high in the thin portion of the septum, which I'll show you a picture of here in just a second, right below the valve planes. Okay. Now, in a normal animal, it goes on one side of the septum is the left ventricle. On the other side of the septum is the right ventricle. Which one of those two chambers has higher pressure? The left ventricle has much higher pressure than the right ventricle. And so if I have a hole in the septum or a VSD, which way is blood going to tend to flow? Is it going to go from left to right or right to left? It's going to go from left to right. Yeah, because it goes from high pressure down to low pressure. So typically, blood flow in a VSD will go left to right, which incidentally was the same as a PDA. Okay. So once the blood flows through the VSD, it goes into the right ventricle and immediately gets swept up and pumped into the lungs and comes back. All that extra blood then comes back and overloads again the left side of the heart. So just like in a PDA, it's weird. We have a left to right shunt, but that doesn't result in a volume overload of the right heart. It results in a volume overload of the left heart. And that's because all of the blood that comes through the VSD is immediately swept into the lung and ends up back in the left side of the heart. Okay, let's look at an example of what one of these VSDs looks like if we want to look at our same little chart. So here's our same heart. Okay, so now we have, here's the left ventricle, here's the right ventricle, and here's the interventricular septum. Okay, in this particular case, we have a hole in the septum. Okay, and it allows communication of blood between the left ventricle and the right ventricle. Okay, so we got a big hole that's in the septum. Now we said it usually occurs high in the septum in the membranous portion of the septum. Well, this portion of the interventricular septum and let me ask y'all a question. When I'm moving my mouse right now, can y'all see it? Okay, perfect. So this portion of the septum is thick and it's muscular, just like the walls of the ventricles. Okay, but high in the septum, it's just a really thin little membrane, and that's normal. But the VSD is where you have a hole in that thin membrane, and it allows this direct communication of blood to go from the left ventricle to the right ventricle. And being that the left side of the heart has higher pressures than the right, when you have one of these, blood then, when every time the ventricle contracts, some of the blood is going to go out the right way, out the aorta, but some of the blood is going to go through this hole and end up back in the right side of the heart, which immediately gets swept off into the pulmonary artery, goes to the lungs, goes to the pulmonary veins, and ends up back in the left side of the heart. So again, it's another situation where we have a left to right shunt, but volume overload of the left heart. Okay, so that's a VSD. And what is a VSD? So what do you would imagine that you're going to see radiographically in a dog that has a VSD? Again, because it volume overs the left side of the heart, you're going to see dilatation or bulging of the left ventricle and the left atrium. Okay, you might see a little bit of prominence of the right heart. So in my experience, what you typically see is not a lot. You see the heart just looks kind of big and a little bit more rounded than it should. So here is a cat with a VSD. This side of the heart up there where the atria lives is just kind of bulgy. It's kind of big. It's subjective. It's kind of iffy, truthfully. On the VD view, again, this part of the heart just looks a little bit bigger than it should. So it's one of these things that if somebody would put these radiographs in front of me and said, read these, and they would tell me that it's a young cat, I would say, yeah, the heart looks a little bit enlarged. And, you know, I would, if he has a murmur, I would do an echo and see if there's a congenital heart defect. If I'm looking at this and I say it's a young cat, I'm not going to look at it and specifically say, yep, I see a VSD. I would have to do other tests to confirm that, but I might get a little bit of a suspicion that this might be a VSD. Okay. So here in the old days, again, we used to contrast these. And so we put a catheter down in here, it's down the carotid artery. The catheter ends up in the left ventricle. We inject this white iodinated contrast material. When the left ventricle then contracts, the majority of it goes out where it's supposed to, into the aorta, but some of it goes right through this little hole right here. And that little hole is the VSD. And so some of that blood and that contrast material now is going to go fill the right side of the heart as well. This is the right ventricle. So that little communication right there is the VSD. Okay, so what do you do about a VSD? Is there a way to treat a VSD? And the answer to that is not really. Okay, in people, they sometimes will put a graft in here to try to fix it. In animals, there's very few places that will attempt these with varying and not really great success. Okay, obviously, with all of these congenital heart defects, the sooner you diagnose them, and if you're going to fix them, the better. Okay, if you let it go too long, you're going to get abnormalities that occur with the heart elsewhere that are not going to be able to be reversed. So you want to catch these early, like with any disease, and go ahead and fix it. Okay. The good thing about that in these dogs and cats, if the VSD is relatively small, like this one, a lot of times as the animal matures and gets bigger, they will heal themselves. They actually occlude. On the other hand, if it's a really large bore VSD, that's not going to probably happen. Without treatment, some of these dogs that have really small VSDs, they'll do fine. They may be totally asymptomatic. Okay. On the other hand, if they have large bore VSDs, they probably won't make it to be a year of age. Okay, atrial septal defect. This one we're going to go by really quick because for a few reasons. It's the same thing as a ventricular septal defect, except this one happens in the membranous portion of the intraatrial septum. So that divides the right atrium from the left atrium. Okay. There's two types we don't need to worry about. There's ones that occurs in dogs, ones that occur in cats. Typically, the shunting is again still left to right because the left atrial pressures are a little bit higher than the right atrial pressures. Okay. And why do we need not to worry about these? Because the great majority of these is the dog is completely asymptomatic. They show no clinical signs at all, and you wouldn't even know they had it unless you would listen to their heart, and they might have a really mild murmur. And there's no fix for them anyway. And so most of these ASDs, you have a totally normal dog, and radiographically the heart looks totally normal, but they have a murmur. Okay, and you can diagnose it with an echocardiogram with ultrasound. But even once you diagnose it, the dogs they're asymptomatic, there's no surgical fix, and most of these dogs will have a normal life. And so that's pretty much all you need to know about an ASD. So here's our cartoon again, here's our picture of our heart, and now you can see here's our left ventricle, left ventricular free wall, the interventricular septum. Here's that thin membranous portion of the septum. If he had a VSD, that's where the hole would be, right through there. But in this particular case, he has an ASD. So here's the right atrium, here's the left atrium up in here, and we have this little hole between the two atria, okay? Okay, tetralogy of Fallot. This one's an interesting one. Tetralogy, obviously, is a fancy word for four things. And classically, when you read about a tetralogy and you learn about it in cardiology, it consists of four separate defects in the heart or next to the heart. Okay, one of them is a pulmonic stenosis, which we're going to talk about more specifically by itself in a minute. One of them is a ventricular septal defect, which we already talked about. The third thing that these animals will have is right ventricular hypertrophy. So the right ventricular wall becomes as thick or thicker than the left ventricular wall. And then the fourth thing is what's called an overriding aorta. So it's easier to remember these, and in reality, it's really only two defects, two primary defects of the heart, and the other two are sequela or secondary to the first two defects. So in reality, you get a pulmonic stenosis, which we'll talk about. And the pulmonic stenosis actually is the thing that causes the right ventricular hypertrophy. Then you also have a VSD, but the VSD is the thing that actually causes the overriding aorta. So the bottom line with the tetralogy of Fallot, classically, people will consider it as four problems. In reality, it's only two problems, and the other two of the four are sequela to those first two. So it's a little complicated, I would guess. So if we look at this, Tetralogies are pretty common in Keyshounds and Bulldogs. I mean, Bulldogs are your best friend because they will make you a lot of money in your practice because they're congenital nightmares, right? But this is pretty common in these. It can happen in any dog, but pretty common in these. Again, the pulmonic stenosis, which is one of the defects, will lead to right ventricular hypertrophy, okay? And the result of this is these dogs will have a lot of exercise intolerance. They'll have low blood oxygen levels. They have high red cell count levels, so they'll be polycythemic. So instead of having a PCV in the 40, 45% range, it may be 60 or 70%, okay? And that's because in turn, the body is hypoxemic. And because of that, it says, well, let's make some more red blood cells to carry what little oxygen we have around. And so we make too many red blood cells, okay? So they can have lots of different clinical signs due to this defect. Let's look at our cartoon, and I think that will help you understand exactly what the tetralogy is. So again, we have a VSD. So we have this communication between the left ventricle and the right ventricle, okay? And in this particular case, with the tetralogy, we also have a narrowing of the pulmonary outflow tract, and that's called a pulmonic stenosis, okay? And so if I have that narrowing, then every time in a normal animal that the right ventricular region contracts, it should pump blood out into the pulmonary arteries. But if this place is narrowed, that leads to increased resistance, so it has a real hard time pumping blood out into the pulmonary arteries. In a dog with a tetralogy, where's that blood then going to go? It has a hard time going this way, but it has an easy time going through this VSD. And so some of these dogs will have a right to left shunt through the VSD because of the pulmonic stenosis. Okay. So we have 4 different defects with the tetralogy. Okay. We have a VSD, which you can see here. Okay. We have a hole in the septum. Okay. The VSD will also lead to this, what they call the overriding aorta. Here's the aorta coming down, and the aorta normally should connect to the left side of the heart, but because we have no part of the septum here, it's kind of straddling both sides of the heart. So it's an overriding aorta. Okay. On the other hand, we have a pulmonic stenosis, the narrowing of the pulmonic outflow tract. And the 4th thing that goes along with it is because of the heart has a hard time pumping blood out the pulmonic outflow tract, the right ventricular free wall becomes thick. It becomes hypertrophied just like the left side. So it becomes as thick, or in time becomes thicker than the left ventricular free wall. Okay, so we have, with the tetralogy, we have a VSD, and due to that, we have an overriding aorta because the aorta now is kind of straddling both sides of it. And we have a pulmonic stenosis, and the pulmonic stenosis leads to increased pressures in the right heart. And as a result of that, the right ventricular free wall becomes thick. Okay, how do you fix a tetralogy? What's the prognosis? As far as I know, and the cardiologist may tell you differently, but as far as I know, there's no way to fix it. And the dogs usually have a pretty poor prognosis, and you're lucky if you can get them out for maybe a year or 2. So symptomatic medical management is probably the only way to go. So here's a dog with a tetralogy. The lateral view is not very helpful. Heart maybe look a little bit big, but really not very helpful. The only sign I've ever seen with a tetralogy is this. A lot of times you'll get kind of enlargement of the main pulmonary artery segment, and you get this weird, almost like a divot, like a concavity of this portion of the heart right below the MPA. And it used to be that in the human literature, they described this defect, kind of this concavity, is causing the heart to be somewhat boot-shaped. Now, this doesn't look like any boot that I've ever seen on this heart, but they have described it as being boot-shaped. So if you have a really good imagination and your imaginoscope is turned up really high, you might be able to say that looks like a boot. But I don't know any other defects will cause a concavity right underneath the MPA. So that's one thing I look for if I'm trying to discover one of these radiographically. And again, the only way to definitively diagnose it would be do an echocardiogram or an ultrasound of the heart. Okay, pulmonic stenosis, we just touched on that. Sometimes you can have a dog that will have a pulmonic stenosis just by itself. That's all it has is that abnormality. Again, bulldogs, the chondrodystrophic dogs, chihuahuas, it can happen in any dog, but most common in small breed dogs. Most of these cardiac defects are most common in small breed dogs. So again, if I look at a pulmonic stenosis, let's look at a picture. I think that will help reinforce it. So now we have, here's our cartoon of our heart again. So here's our left ventricle, here's our right ventricle, here's our septum. The septum's complete in this, it's intact. There's no hole in it, right? But now I have this narrowing at the level of the valves in the pulmonic outflow tract. And so if I, it's like a garden hose and you put your finger on the end of the hose, the pressure in the hose is going to go up, right? And the jet that comes out of the end of the hose is now going to be a small diameter jet with high velocity. Okay. So basically this pulmonic stenosis is I'm putting my finger and occluding the outflow where the valves are, the pulmonic valves. And because of that, everything in front of it, right in here, the right ventricle, the pressures are going to increase. And as the pressures increase, the heart, the body thinks, well, we can't get blood out to the pulmonary artery segment easy anymore. So the way we're going to do that is we're going to make this muscle stronger and thicker to try to get more blood through that narrowed area. On the other hand, we get this jet of high velocity blood coming from the pulmonic stenosis, and it will cause over time this eddy formation and turbulent blood flow, which causes the MPA, the main pulmonary artery segment, to become enlarged. And so a pulmonic stenosis, typically we get enlargement of the right side of the heart, we get thickening of the right ventricular free wall, and we'll get a bulge of the main pulmonary artery segment, and they have a distinct murmur. Okay. So if I go back and I look at a radiograph of one of these dogs, I get enlargement of the right side of the heart. Look at this great big bulge over here in the MPA region. That's the 1 o'clock position. Okay. There's not much else except for one of the acquired heart diseases we're going to talk about that will cause this big prominence of the MPA. So in a young dog, big right heart, big bulge of the main pulmonary artery segment, and he's got a murmur. Okay. Most of these dogs clinically, they will pass out. So they'll be running around and, for 3 or 4 minutes, and suddenly they just quit, and sometimes they'll just completely pass out and they recover. But that's because they can't get enough oxygen to their lungs because of this occlusion of the blood trying to get to the lungs. Okay. Lateral view on a dog with a pulmonary stenosis a lot of times is not helpful. Sometimes you'll get a little bit of enlargement up in here, but usually not very helpful. So the VD view is the one that is going to help you the most. Here's a contrast study of a dog with a pulmonic stenosis. Again, got a catheter. This is inside the right side of the heart. You can see how thick the right ventricular free wall is. Normally it should be really thin, but it's really thick. And now we have contrast that's coming out. We got a little bit of a bulge up here in the right atrium. This is the narrowed area. That's the stenosis itself in the region of the valves, the pulmonic valves. And after that, we get this great big MPA bulge that lives right up in here. And that's because we have this high pressure jet that's like you're putting your finger over the hose, and it's squirting this high pressure jet of blood inside the main pulmonary artery segment. And over time, it becomes big and dilated. Okay, that's pretty thrilling, I can tell. Okay, the next one we're going to talk about is aortic stenosis. And the aortic stenosis is very similar to a pulmonic stenosis, except instead of involving the aortic valves, this time it involves the aortic valves. Okay, so let's look at an example of what an aortic stenosis is, and then we'll talk a little bit more about it. So with the aortic stenosis, this happens on the left side of the heart. So here's our left ventricle. Normally, when the left ventricle contracts, it should pump blood out the aorta. Okay, but in this particular case, we have a narrowing of the left ventricular outflow tract. And because of that narrowing, every time the left ventricle contracts, it has a real hard time pumping blood into the aorta, or enough blood. Okay. And because of that, the body's response is, well, we can't get enough blood out the aorta. So over time, it says, well, let's make the muscle around the left ventricle bigger and stronger. So you get all this severe thickening of the left ventricular free wall and thickening of the septum. So it can hopefully pump more blood, oxygenated blood out the aorta. So that's an aortic stenosis. So what do you think you're going to see radiographically with aortic stenosis? Well, as the free wall, the left ventricular free wall and septum get bigger and bigger and bigger, we get enlargement of the left ventricle. Then you have to think back to the clock face. Where does that live? When blood comes from the left atrium and trying to get into the left ventricle, it probably has a harder time getting blood into there because the left ventricle is already full. It can't get rid of its blood. And so now we get dilatation of the left atrium. And then we get also, because of this, again, you put your finger over the end of the garden hose, you get this high jet velocity. Typically, these dogs will get dilation or prominence of the ascending or ascending portion of the aorta. So notice that this ascending portion of the aorta is wider than the descending portion of the aorta. So typically with an aortic stenosis, what you see is you will get enlargement of the left ventricle and the left atrium. You might get some pulmonary venous enlargement, and you get this post-stenotic bulge of the ascending aorta. Now you remember when we talked about PDAs, you got a bulge of the descending aorta, right? In this particular case, we get a bulge of the ascending aorta, so it's a little bit different. Okay, so radiographically, what do you see on radiographs when you have a pulmonic stenosis? Is you will see enlargement of the left ventricle, so that becomes a little bit enlarged. Our left atrium right up in here at the 1 o'clock position becomes a little bit enlarged, okay? And then we lose this normal cranial appearance of the heart because the ascending aorta is coming right around in here and it becomes big and prominent. And so we get kind of a bulgy area in the region of the ascending aorta. On the VD view, again, we get prominence of the left side of the heart, really not that to be that prominent to me, but we get this widening of the mediastinal space. And this is because we get this widening or dilatation of the ascending portion of the aorta that's coming around in here before it comes down. With the dog with a PDA, we would get prominence down here in this portion of the descending aorta. In dogs with aortic stenosis, it's way up here high in the ascending portion of the aorta. So what is the fix for a dog with a aortic stenosis? There is none. They really can't do much about them, treat them symptomatically, and these dogs will be lucky if they make it to, again, a year or two of age. Here's a contrast example, again, a contrast where we put a catheter in the left ventricular region, injected the contrast, which shows up white. Here's the aortic arch. Look at how wide and prominent the aortic arch is up in this region here. And this area right in here is super narrowed, okay? As the blood tries to get out of the left ventricle, it goes into this is the sinus of Valsalva, the base of the aortic arch, and we have this super narrowed area right in here. That's the stenosis itself. Okay, some of the more unusual ones, and again, we're just gonna breeze through some of these. Most of the time when you have a PDA, we discussed that the blood flow goes in what direction? It goes from left to right, typical PDAs. And even though it's a left to right shunt, it will volume over the left side of the heart. There are occasions where the blood flow actually flows the opposite direction in the PDA, and that's called a reverse PDA. And the cardiologists will look at these, and these, if you ever have a dog with a reverse PDA, the murmur will be a little bit different. They still will have a murmur most of the time. The clinical signs will be a little bit different. The physical exam findings will be different than you have a dog with a PDA. And these dogs with reverse PDAs, there really isn't a good way to fix them. If you tie the PDA off, if they have a reverse PDA, you'll usually kill the dog. So it doesn't work really well. So these dogs end up with Eisenmenger's physiology, which you probably studied a little bit about in physiology, and it's beyond the scope of this class, at least right now. And the cool thing about these dogs with reverse PDAs, you'll hear that murmur, kind of a PDA-like murmur, but these dogs will have differential cyanosis. And so their cranial end, so their tongue and their head and their front limbs will be nice and pink, nice pink mucous membranes, but the caudal end of the dog, so the rear end, the tail, That's kind of, the rear limbs, they will have blue mucous membranes. So the front end is pink, the caudal end of the dog is blue, it's cyanotic. Okay, and that's because of where the PDA is located. And now we have blood going from right to left instead of typically from left to right. Again, surgical fixation is not possible. I'm not going to waste any time. This is just some contrast examples you can look of a dog that has a reverse PDA. Okay, mitral valve dysplasia. This is a pretty common defect. Where's the mitral valves? You remember where anatomy-wise they're located? Very good. The mitral valves are located between the left atrium and the left ventricle. Okay. Normally, those valves should allow one-way blood flow. So anytime blood goes into the left atrium, it should flow then through the valve plane, through these mitral valves, and go into the left ventricle. They should allow one-way blood flow. So it allows blood to go from the left atrium to the left ventricle. But when the left ventricle contracts, these valves should shut normally and should not allow blood to go back up into the left atrium. So they're one-way valves, and they should be nice and paper thin, and they move really nicely, and they coapt together. When they open and close, they come together like that, okay? Dogs with mitral or tricuspid valve dysplasia, the valves aren't formed right. So they're either knobby, so they're like this, and they don't form right, and they don't open right, and they're clunky, and they're disorganized and uncoordinated. And when they close, there still may be a hole between them. And so dogs with mitral and valve dysplasia, the valves don't form right, and they become leaky. So now instead of having nice paper thin one-way valves, we have clunky, irregular, knobby valves that allow blood flow to go both ways. Okay. Mitral valve dysplasia is really common in cats and especially common in King Charles Cavalier dogs. Okay. The King Charles Cavaliers also have lots of problems, which we'll find out when we talk about the neuro stuff coming up. Okay. Tricuspid valve dysplasia can also happen in Labradors and also King Charles Cavaliers. So what do you see radiographically with these dogs? You typically see enlargement of the atrium and the ventricles on both sides. There's no way to fix the valves, at least that I know of. In people they do, but I don't think we're doing that in animals. And so you treat them medically for evidence of and signs of cardiac disease and heart failure. Okay, some of the real rare ones, and again, we're not going to talk about these other than just page through them real fast and mention them. These are the ones that you may see if you get under a cardiology rotation at a teaching hospital or a specialty clinic that has a cardiologist. Some of these you can fix, some of them you can't. Some of them are exceedingly rare, but they're kind of cool to at least mention. And you should probably at least have in the back of your mind, yeah, I've at least heard of that. Okay. So we mentioned before, we mentioned a tetralogy of flow. A triology of flow is where you get atrial septal defect, a pulmonic stenosis, and right ventricular hypertrophy. These dogs usually are going to be normal. They may have a little bit of cyanosis. Then you also have a pentalogy. So instead of 4 defects, now you have 5 defects. So you have a dog with a tetralogy, and you can add an ASD on top of that, and that's a pentalogy of flow. Another one's called a persistent truncus arteriosus. This is where you have one common artery leaving the heart. So instead of a caudal vena cava and a pulmonary trunk, you have, instead of a pulmonary vein coming out of the heart, a main pulmonary segment and aorta, you have one common one. Obviously, that's not going to work out so well. So that's called a persistent truncus arteriosus. Again, prognosis is really poor and no real treatment for that. A coarctation of the aorta, I've seen this a couple of times in my career. It's kind of a cool thing. And this is where the aortic arch, you can see it coming around in here, you get a stenosis of the aortic arch somewhere in the descending aorta, and it can be really severe, okay? And this is, it's a congenital defect, again. Most of these dogs will have a pretty poor prognosis because obviously you have this narrowed aortic arch, and that will allow poor blood flow and less oxygenated blood flow to go to the rear limbs and the trunk. Okay, so that's coarctation of the aorta. Here's an example of a contrast enhanced study. So here's the aorta coming down in this animal, and we got this super narrowed portion of it, and then it gets big again. So this narrowing of the aorta is called coarctation of the aorta. An aorticopulmonary window is a large bore communication between the ascending aorta and the pulmonary artery. So it's kind of like a PDA, except it's bigger in diameter. And instead of connecting the descending aorta and the pulmonary artery, it connects the ascending aorta and the pulmonary artery. Again, piss poor prognosis. There's an example of a cartoon of what that would look like. There's a dog that has one. His heart looks real messed up. Persistent left cranial vena cava in utero. A lot of the animals in embryology will, in utero, will have a left cranial vena cava. We know the caudal vena cava and the cranial vena cava on in an adult normal dog is on the right side. But sometimes they will have a persistent left cranial vena cava. And this is an example of a contrast study of the cranial vena cava that is now on the left side. Most of these dogs do pretty well with it. Doesn't really matter to them, and they have a pretty good prognosis. Core triatriatum, I had one of these actually on my board exam when I took the radiology boards. I had no clue what I was looking at. Truthfully, I had heard beforehand that this might be on the boards, and so I was waiting for something that was on it was an echocardiogram, and I had no idea what it was, but I had heard that it might be on the boards, and so I picked it. And I guess I got it right. I don't know. So a core triatriatum is where usually the right atrium or the left atrium has a abnormal septum in it inside the aortic, the atrium itself. So basically it's a soft tissue septum that divides the atria into two parts. Okay, it can have an upper part and a lower part. And most of these dogs, typically they're normal, but sometimes they'll show signs of right heart or left heart failure. And you can echocardiogram them, and you see inside the atria, they have a septum that's sitting in the middle of the atrium, and that's called core triatriatum. Okay, so that is the end of congenital heart defects. I know it's a lot. They're complicated because it makes you review physiology and anatomy. And so the ones that you probably are most important for you clinically that you should know about, I would know the mechanism, direction of blood flow, the specifically what the defect is, the prognosis, and what chambers become enlarged with each of the common ones. And the common ones that you need to know for sure are PDA, VSD, pulmonic stenosis, and aortic stenosis. Those are the big ones you need to really probably concentrate on. Okay. And I know it's a lot of information, and a lot of it is just because you haven't thought about this kind of stuff for a while. But if you sit down and you think about it, use those line drawings that you have, and think about the pressures inside the heart in those chambers. Remember that the blood flow is going to go from wherever the pressure is highest to wherever the pressure is lowest. And think of the mechanism of blood flowing in that direction abnormally. And when you have these abnormal areas of blood flow, it's going to cause those chambers to become enlarged for the most part. And so if you think about the mechanism, exactly what the specific defect is, then you can start to figure out and predict what part of the heart is going to become enlarged. And then again, that goes back to learning the clock face analogy and what chambers and what lives where. Okay. All right. Well, that's probably a good place to stop, at least for